Hello, my name is Dr. Vincent Castiano. I am a board-certified family physician as well as a board-certified pain management physician. I'm going to discuss with you the difference between acute pain and chronic pain, as patients who suffer from chronic pain have more complicated courses and are more difficult to treat, and understanding why that is possible and the contributing factors to it can help you have a more complete treatment plan and hopefully a more successful treatment. The learning objectives are to analyze the differences between the acute and chronic pain, understand how patients can develop chronic pain, and then applying this new knowledge to be able to form a more complete treatment plan. So, acute pain. Acute injuries cause acute pain. It's supposed to hurt. Tissue damage releases biochemicals called cytokines, and they cause inflammation and pain. And this is protective. If you were to twist your ankle or hurt your back, the pain should cause you to rest and decrease the activity level you have, which would decrease any further injury from happening. Typically, when the acute injury resolves, the pain goes away. And almost all injuries that happen will have tissue recovery within 3 to 6 months, even a significant surgery. The problem with chronic pain is that it persists. Even after the tissue damage has healed up, you have persistent pain. Typically starts after 3 to 6 months. And the problem is the main pain generator at that time is the brain as opposed to the tissue. Misfiring of signals from the brain can cause pain that's felt in the tissues. So your brain can send signals that make you feel pain in your knee or in your back. You may see some resources I have from DVCIPM. That's a Defense and Veterans pain organization where they educate both providers and patients. There's an excellent video here at this link. I'll include the link in the YouTube channel for easy access for folks. But I think that their production value is far superior to what I'm providing, and the information is fantastic. So how does chronic pain happen? So what we have here is a chronification of pain cycle, and understanding how these different portions play into each other is very, very important. Every patient who has chronic pain at some point started with acute pain. They had an injury and that injury hurt. But not everybody goes on to develop chronic pain. Most people don't. But if you have pretty significant acute pain and it's inadequately treated, you have a cascade of events that happen that contribute to development of chronic pain. The nerves that carry the pain signal, and taking a step back, in your body, this occurs everywhere and it's normal. If you have a pin stuck in your foot or a thorn in your finger, you actually do not feel that pain until the sensation is carried by a nerve to your brain to be interpreted as pain. Now, the problem is if you have acute pain that is not adequately treated, those nerves will become inflamed over time and become sensitized. And what sensitized means is that they will need less stimulation to take that pain impulse and make it carry across up to the brain. So once the nerves have been inflamed and then they become sensitized, you keep having stimulation sent up to your brain. After you get continued stimulation, then your brain will become sensitized. And we'll talk about all this in further slides. So there's a process called neuroplasticity. It's brain changes. This is normal. We have neuroplasticity. Our brain is amazing, and this is how we learn new tasks. And I tell folks, think about the first time you ever tried to type or play an instrument or do a complex task like shoot a gun or shoot a free throw. What we call muscle memory, colloquially, is not actually muscle memory. It is your brain making new connections. And so when it comes to typing, your brain would need to make new connections between the motor parts of your brain that control your fingers, your visual cortex, and your language centers. So that way you can type while thinking about what you want to type without having to actually look at the keys. And this is possible because our brain undergoes a process called neuroplasticity. So when you keep on exposing the brain to a new task repeatedly, the brain will learn how to do that task more efficiently. And the problem is your brain does this always, including with pain. So if your brain keeps getting pain signals from a sensitized peripheral nerve, over time your brain will get so good at sensing pain, it will start to send pain signals itself. And this process is called central sensitization. So why is chronic pain harder to treat? Why can't I just give you a pill to make your chronic pain better the same way as I would give you a pill to make your acute pain better? And that's largely because the contributors are multifactorial, right? And so because they're multifactorial, you need a multimodal treatment plan. And typically what we have in routine medicine and in primary care and even in pain management is we tend to get a little bit more unimodal, or maybe 2 different modes instead of all the different modes in which need to be exploited to give you the best outcome. If you have a traumatic source of injury, things like war trauma, car accidents, sexual assault, things like that, there's a reason why that kind of pain is harder to treat. You have folks who have comorbid or coexisting anxiety, depression, PTSD. That worsens pain control. Some folks don't sleep well. And if you at baseline don't sleep well, then the chronic pain only makes it worse. Some people who sleep just fine, as they start to develop chronic pain, will notice that their ability to sleep well deteriorates. Kinesiophobia, which is a fear of movement, and we'll talk about that. Central sensitization, which we already talked about. And ongoing tissue injury. Some people who have chronic pain and they have the peripheral and central sensitization, but the actual pain generator doesn't go away. It still is present and is still bothering folks. And because of that, it continues to send up pain signals. And we're going to go into some of these. So traumatic pain. So I challenge you right now to take a moment and stop and think of the most pleasant memory you've ever had. I'll wait. I want you to think of the sounds, the emotions, the smells, the tastes, everything. And when you sit with that thought, you sit with that memory, you will re-encounter the sounds, the smells, the tastes, everything. And it's because we like to think that you have a memory center of your hippocampus in your brain, but really it works more like a network. You have the parts of your brain responsible for sights and sounds and memory and taste, and all of these guys work together to give you a very, very vivid memory. And the problem is, as good as your brain is at remembering very pleasant experiences, it's arguably better at remembering traumatic experiences. And because it's evolutionary, right? Like when you think back several thousands of years ago when we lived in a hunter-gatherer society, if you experienced a very, very scary event, then your brain, to protect you from being eaten by a lion or eating a poisonous fruit, holds on to those memories and allows you to re-experience them to prevent you from doing something that's risky. Now, if you experience pain during this trauma, then you're going to re-experience the pain when you have something that triggers the memory. So some patients have traumatic experiences that result in PTSD. I was a military physician for a long time, and many of my patients fall into this category. Sometimes a sound or something they see or something they smell will bring back a memory very vividly, and it becomes intrusive, and when that memory comes back, it brings everything with it, the sights, the sounds, the smells, and if they experience pain during that experience. Sometimes the pain is enough to actually spark off a traumatic memory because it works in both directions. And so if a patient was sexually assaulted and that sexual assault resulted in chronic back pain, the experiencing of back pain throughout the day can actually have the patient re-experience the trauma of the sexual assault. And as you can imagine, this makes treating traumatic pain very, very difficult to do. There's not going to be a pill or an injection that helps treat traumatic pain. It has to be multimodal with the help of a behavioral health provider. Pain can also cause depression. So if you develop pain and you've had no history of depression or anxiety, it can actually cause it over time. And it makes sense when you think about it. If you're super high functioning, maybe an athlete, and you have pain, and that pain prevents you from being able to participate in the things you enjoy, you are experiencing a loss. You get a loss of function, you get a loss of purpose, you get a loss of sense of self-worth. Maybe your sport or activity was a way of being social, and now you are unable to participate in those things. Or maybe you're in so much pain that you decide to not go to weddings or not go to family get-togethers because the pain is going to be aggravated by activities at those, prolonged standing, prolonged sitting, things like that. And so once you start to lose little pieces of your life and little pieces of things you enjoy over and over and over again, this is going to, over time, give you symptoms of depression or anxiety. Some folks will have so much pain that their ability to maintain employment is impacted, and then they begin to get financial instability, and that by itself is a great reason to develop anxiety. So the problem is you have this portion of your brain, it's actually two portions, that are responsible to work like a dimmer switch to turn pain down. This process is called descending inhibition. The problem is the portions of your brain that are responsible for descending inhibition. Inhibition just means the ability to inhibit, to stop. Descending means coming from the brain down. These portions of the brain are negatively impaired when you have depression or anxiety. So people who have chronic pain and have depression or anxiety have an inability to tolerate the pain. Their pain tolerance goes down. There's something called the sleep pain cycle. So if let's presume you sleep well at baseline. If you sleep well and you have an acute injury or pain, typically what happens is you reset your pain thresholds when you sleep. So sometimes you'll have a headache or back pain, and you're like, oh, I just need a good night's sleep. You have a good night's sleep, you wake up, the pain is decreased. It may not be gone, but it's significantly decreased. And that is a normal process that your sleep thresholds recycle when you get deep restorative sleep. But if you have sleep disorders, either organic sleep disorders, meaning something that is like innately, objectively seen, something like sleep apnea, restless leg syndrome, things like that, it's going to impair your sleep, impair your ability to get restorative sleep, and your pain thresholds will not reset. If you have horrible pain, sometimes you just cannot get comfortable and you toss and turn all night, that is also going to prevent you from getting deep restorative sleep. People who have depression or anxiety also notice a worsening in their sleep. And this is quite normal, either difficulty falling asleep with folks with anxiety or mid-evening awakenings, which is pretty typical of patients with depression, or a combination of the two if you have both, are all going to impact your sleep. So patients with impaired sleep have impaired pain thresholds. And so these patients typically over time will start to have worse pain because in part due to their poor sleep. Central sensitization we talked about already earlier, with your brain becoming more sensitive to painful input because of reorganization and essentially developing muscle memory for being in pain. And if you find a way to turn off the nerves, right? So let's say you have chronic knee pain and you were to perform an RFA and burn the nerves to the knee. What you may find is that not all the pain actually goes away, despite the fact that you have a completely numb knee. You'll still have some pain, and that pain that's left over is actually from the brain. Some people, if they've been in chronic pain for a long, long time, decades even, you do these interventions that typically do work on folks, like epidural steroid injections, nerve RFAs, things like that, and they don't get good pain relief. And they don't get good pain relief because largely the pain signals they continue to experience can be coming from the brain, which makes it very, very difficult to treat. Kinesiophobia. So this is fear of movement. So what typically happens is you start to fear doing the activities you used to be able to do because you're scared of exacerbating your pain. So typically what happens is, someone starts to develop, let's say, knee pain, and they're an avid jogger, and they're having a bad knee day, and they're like, well, maybe I'll run tomorrow because my knee hurts today, and then they'll run. And when they run, they experience a little bit of pain, but like, no big deal, I'll just keep running and the pain will go away. And then it starts to be like, I'm not going to run I'm not going to run as far because I'm starting to experience pain. And then that turns into, I'm just not going to run anymore because I have pain. So it's this gradual loss of physical functioning because of fear of injury. And then what inevitably happens, especially if someone's a prior athlete, is they stop doing the things that hurt. And then one day they get fed up of their inability to do the things that cause them pain. And they go and they do it, right? So I'm an avid jogger. I stop jogging for maybe 6 months because it hurts. And then I get fed up with not jogging. So I go and I jog. But instead of easing in really slowly, I just jog at the same rate and distance that I've done in the past. And then I hurt myself, which only reinforces I knew I shouldn't have ran because I knew I was going to hurt myself. And then what happens is you stop doing activities that you find meaningful or activities that provide exercise and strengthening and stretching. And these are things that decrease injuries. So kinesiophobia, which causes you to develop weak muscles and tight muscles, and typically stress relief from the activities, the kinesiophobia makes you weak, it makes you tight or inflexible, it makes you more stressed out, and makes you more prone to injury from day-to-day things like picking up laundry, climbing stairs, and things like that because your activity level has decreased. There's actually a really nice study that was performed in JAMA Psychiatry in 2022 looking at patients with significant kinesiophobia and significant chronic pain and doing what's called reprocessing therapy. So it was 3 arms. One arm of the study did nothing. One arm of the study had usual care, which is usually things like physical therapy and medications. And the other arm had reprocessing therapy. And what this is largely you go and there's an activity that hurts. Let's say going for a walk. And you go for a walk because you're able to recognize that going for a walk is unlikely to cause injury. It just may hurt a little bit. And so you go for a walk, it starts to hurt a little bit, you take a break, and then you increase that activity slowly over time. And what you notice is you're able to reprocess and take advantage of the neuroplasticity that your brain's already doing, and you're able to reprogram your brain that things like climbing stairs are non-injurious, going for walks are non-injurious, exercise is non-injurious. Will it hurt? Yes. Will it injure you? No. And over time, as you start doing these activities again, you're able to reprogram your brain back into having a higher degree of function, and having a higher degree of function decreases pain over time. And so it's super powerful. The ability to have neuroplasticity can work against or for you. And then, of course, there's ongoing tissue injury. Some people will have ongoing tissue injury. So a lot of folks have a tear in their disc in their back. And periodically, if they lift something wrong, a little bit of the jelly in the disc will leak out, and that can cause pain. And so if you are already with sensitive peripheral nerves and a sensitive brain, then you have ongoing tissue injury, it's going to hurt. It's going to hurt a lot. And most tissue injury resolves within 3 to 6 months again. But you can have periodic flare-ups, and having periodic flare-ups with central sensitization is really, really tough. And so the reason why patients with chronic pain are so difficult to treat is because they're a perfect storm. Many of them will have ongoing sources of pain. Almost all of them will have peripheral and central sensitization, which decreases their pain thresholds. They get poor sleep, which decreases their pain thresholds. And they may have underlying mood disorders like depression, anxiety, or PTSD, which decreases their ability to tolerate the pain. So the thresholds are what causes pain, and toleration is, okay, I have pain, am I able to turn that pain down so that I can get on with my day? And having all of these, the patient will develop kinesiophobia over time, and that will increase their risk of injuring themselves further in the future, and it'll give them decreased function. So you can very easily, in a course of 5 to 10 years, probably even as low as 2 to 3 years, take somebody who is fairly athletic and high functioning, give them chronic pain, and then through the process of kinesiophobia, have them largely just wake up, do their daily activities, and sit on a couch all day. So because you have a multifactorial cause of pain, you need a multimodal treatment plan. So if you wanted to do the best, most work for a patient, it can't just be with a pill, and it can't just be with a shot. Patients who have traumatic pain need to have behavioral health therapy. PTSD is highly treatable, and the treatment process of it is not short and it's not easy, but it significantly improves treatment outcomes. And PTSD is one of the highest rates of successful treatment of mood disorders. Patients with depression and anxiety symptoms, same thing. They need behavioral health. They could benefit from meditation techniques, which may help their anxiety symptoms. Some medications may be helpful. Cognitive behavioral therapy can be helpful. That's CBT. CBTP is a kind of cognitive behavioral therapy for patients with chronic pain, which can also be very, very beneficial for folks. Folks who suffer from a sleep pain issue, cognitive behavioral therapy for insomnia has evidence that it's as effective as Ambien for helping people get to sleep, which is super helpful. If they have other organic issues, sleep apnea and stuff like that, they should see a sleep physician to get a sleep study to determine whether or not there's anything in addition that's worsening their ability to sleep. And then, of course, there's oral medications, and there's lots of different oral medications you should talk to your primary care doc about that are non-habit forming and won't interact with your other medications. Kinesiophobia, or central sensitization with it, this is going to be probably the hardest thing to treat, but you can get there with physical therapy, cognitive reprogramming, which is largely going to be a combination between CBTP and behavioral health. Movement therapy is highly, highly underutilized and has fantastic evidence for, especially for patients who have things like fibromyalgia. So yoga and Tai Chi routinely have the best evidence for patients with fibromyalgia, and it's largely because of their combination of their breathing techniques along with their exercise and gentle stretching. Tends to work both to decrease anxiety and depression symptoms as well as restoring function and flexibility. Now, the ongoing tissue injury should largely be where traditional medicine lies: physical therapy, oral pain medications, interventions like epidurals or steroid injections, things like that. Proper ergonomics. Like if you work at a desk, your ergonomics should be squared away, because if you are sitting in a position that causes pain and you do that for 8-9 hours a day, then you're going to be in pain and you're going to continue to wear out your discs or injure your knees, things like that. And weight loss is also important for a number of reasons. One, it just takes weight off joints. So very simply, if you are overweight, it puts increased pressure on the lower parts of your back, your knees, and everything below that. And secondarily, having extra weight on you, particularly abdominal fat, is pro-inflammatory. And there was a study to show that patients who lost abdominal fat actually decreased their hand arthritis symptoms. And this is possible because it is inflammatory. It causes every spot in your body that has a little bit of arthritis to ache. So if it's not about aesthetics, and as long as you're happy with the way you look, that's all that really matters. But in reality, your knees and your back and arguably other sites in your body that have arthritis will suffer as long as you have extra abdominal fat, which is very pro-inflammatory. So these are some helpful resources that I like to use from DVSIPM for both provider education, which I do, as well as patient education. So here's the website here. Again, I'll include a link in the profile to help you access some of these. I hope you enjoyed the video. In summary, the most important thing to understand is that patients who suffer with chronic pain are not the same as patients who have acute pain. And because the pain has multifactorial causes, it needs a multimodal treatment plan. And what's important to understand is to take a moment to be introspective and think about the different things that are contributing to your pain, and work with your physician to have a multimodal plan so you can have your best outcome. All right, well, this is Dr. Cassiano, and I hope you enjoyed the video, and stay well.